Chapter 15, Urinary Renal System, Screencast 5. Now, as noted previously, the kidneys maintain homeostasis a variety of different ways. The first two are highly integrated to each other. We're talking about maintaining water balance and also maintaining salt balance. So if I add water, that's going to dilute the salt. If I add salt, it's going to dilute the water. So you can't change one without changing the other. That's the important point I'm trying to make here. Okay. Also, another factor that's going to be controlled by the kidneys is going to be blood volume. And if you control blood volume, that impacts blood pressure. Additional things that the kidneys are responsible for maintaining within normal limits are acid base in the blood, the regulation of red blood cell production, and that was through erythropoietin or EPO, and also to activate an inactive form of vitamin D. Now, the first thing that we're going to look at is antidiuretic hormone, which we talked about in the previous screencast, and how that regulates water balance. So the following organs are going to be involved. The hypothalamus, that's where ADH is actually secreted. The posterior pituitary, that's where it's actually stored and released from. And then the kidneys are the target of ADH. So really what we'll be looking at here is a negative feedback loop that regulates the solute concentration of the blood. That's important because that is the primary thing that is going to cause the release of ADH. It's going to be an increase in plasma solute concentration. So that's the important thing. Okay. Another factor that will cause the release of ADH is going to be a drop in pressure, but the strongest stimulator is going to be the increase in plasma solute concentration. So what we're going to see here is either an increase or a reduction of ADH secretion, and that will actually modify the water reabsorption being done by the kidneys. So the other thing that's going to play a role here is thirst will either be increased or decreased depending upon the desired response. Now, if blood solute concentration is too high, so low water volume, there's that release for ADH again. Remember that high plasma solute concentration. ADH is going to cause an increase in the permeability of the collecting duct, and remember that's within the nephron, to water. That's going to increase the water reabsorption by the kidney. And if I have more water reabsorbed, that's a decrease in urine production, but also an activation of the thirst center to increase thirst and force you to drink more. If blood solute concentration is too low, so now there's too much water, you've got to decrease the secretion of ADH. This is the reverse of what we saw previously. So there's going to be a decrease in permeability of the collecting duct to water. Less water is going to be reabsorbed by the kidneys, resulting in greater urine production and also a corresponding decrease in thirst. Now, you may have heard of the drugs called diuretics. And a diuretic is any substance that increases the formation and excretion of urine, and that process is known as diuresis. Lasix, that's a diuretic. It's a medication that reduces blood volume and blood pressure. It's used to treat congestive heart failure and hypertension. Caffeine also acts as a diuretic because what it does, it inhibits sodium reabsorption. And alcohol has its diuretic effect by inhibiting the release of ADH. So let's walk through the mechanism here. So notice what's happening to blood solute concentration. So remember, that's the primary stimulus for the release of ADH. That's detected within the hypothalamus, telling the posterior pituitary to release ADH, but also to increase thirst. So the kidneys are going to be reabsorbing more water due to the increased permeability in the collecting duct. This is going to result in a decrease in the renal water loss. So this is going to be added to the urine. So there's more water being reabsorbed. And overall, we're going to be looking at a normalization of plasma solute concentration because you've increased water reabsorption and you've started to dilute the salt. blood volume control is also dependent upon salt balance. Now, aldosterone is a hormone from the adrenal cortex that regulates sodium excretion. An increase in sodium reabsorption from the distal tubule and collecting duct is how aldosterone actually works. The release of aldosterone is actually controlled by the renin-angiotensin system. Now, in class, I indicated that I would be really clear on the review sheet as to what I want you responsible for on this mechanism, and I did so. But I want to walk through this whole process because there's some terms here some of you that work in the medical field may have heard already. You may have heard of some of these medications that are related to this mechanism. So I'm going to walk through the whole mechanism. So the release of aldosterone is stimulated indirectly by a decreased blood volume, which generally would result in a lower blood pressure. The lower blood volume, blood pressure, causes the release of renin, and that's coming from the juxtaglomerular apparatus, and that's an area where the afferent and efferent arterioles are really close to the distal tubule. Now, there is a protein circulating within our blood called angiotensinogen. Renin, which is released, is going to be responsible for activating or converting angiotensinogen to angiotensin 1. The thing we want to remember here is angiotensin 1 is not active. Okay? There's an enzyme called angiotensin converting enzyme, and this is in the lungs, and that converts angiotensin 1 to the active form angiotensin 2. So remember, angiotensin 1 is not active, angiotensin 2 is, and it's activated through angiotensin converting enzyme. So important, confusing, but I want us to kind of get the idea of this mechanism. So here what we're going to look at is how it's actually detected. So we can actually see the afferent and efferent arterioles running very, very close, okay, to this area, the juxtaglomerular apparatus, and that's able to detect solute concentration. And so that's where renin is coming from. Now, angiotensin 2, what I want you to know about that, it's a very potent vasoconstrictor. That is definitely something I will ask you. So you want to know angiotensin 2 is a very potent vasoconstrictor. And so because it's a potent vasoconstrictor, it's going to cause an increase in resistance, which causes blood pressure to go up. It's also going to stimulate the release of aldosterone from the adrenal glands, and aldosterone will increase sodium reabsorption in the distal tubule and the collecting ducts. Now let's kind of walk through this diagram, and what we're looking at here is a decrease in blood volume, okay, and that's going to result in a decrease in pressure also. So overall, we're really looking at a mechanism that's responsible for helping to increase blood pressure, and it's going to happen through the regulation of water volume. So we go to the kidneys, we're actually going to see renin being released. Now remember, angiotensinogen, that's circulating and it's produced by the liver, and renin is going to activate it into angiotensin 1, which is not active. Okay? As it's in circulation, it goes to the lungs. That's where angiotensin converting enzyme is. And now it's going to be converted into angiotensin 2. And that's going to be a very potent vasoconstrictor to help rise blood pressure. Okay? Angiotensin 2 is also going to cause the release of aldosterone. So that's going to save salt. Okay, so you're going to be doing that. And then you're also going to be saving water. So that's how you're basically going to be overall increasing blood volume and increasing blood pressure. So very important pathway that comes into play when pressure is actually dropping. ACE inhibitors, they are a medication for the treatment of high blood pressure. This is actually the medicine that I take to control my blood pressure. I have severe hypertension, but it's really well controlled. When I was first diagnosed as a hypertensive individual, my blood pressure was actually 190 over 110. And if we go back to when we talked about risk factors for heart disease, that's considered stage 2 hypertension. So really, really high blood pressure. But this drug, the ACE inhibitor that I take, does a really, really good job at keeping my blood pressure down within normal limits. So what an ACE inhibitor is going to do, they prevent the normal production of angiotensin II. So there'll be less aldosterone. There's going to be an increase in sodium and water excretion. So there'll be a little bit of a shift in blood volume. That's going to be reduced slightly. But blood vessels will actually dilate, lowering blood pressure. So that's how we actually see all of this kind of connect together. And once again, ACE inhibitors are a really, really good drug, not a lot of side effects that a lot of people that have high blood pressure take. Now, the only hormone that comes into play when blood pressure goes up is this hormone ANH. So this is going to be stimulated when there is an increase in water volume or an increase in blood pressure due to that. So this higher volume of blood, it stretches the atria of the heart. So they're responsible for secreting this hormone in response to that stretch. Now, ANH, that's going to prevent sodium reabsorption in the distal tubule and the collecting duct. So it's not being reabsorbed, it's going to be excreted. Water follows solute, and the effect of ANH is exactly opposite to that of the aldosterone. So this is actually going to help lower blood pressure, not increase it. And once again, ANH is the only hormone that comes into play when blood pressure increases. All of our other hormonal mechanisms are stimulated by a drop in pressure.